I'm really pleased to introduce our next session entitled Harnessing Intrinsic Tissue Regeneration Through Mechanical Stimulation. Our first speaker is Dr. Christopher Evans. He's a professor of physical medicine and rehabilitation and orthopedics at the Mayo Clinic. He is also the Maurice Mueller Professor of Orthopedic Surgery Emeritus at Harvard Medical School. Trained in molecular biology in Europe, he came to the University of Pittsburgh Medical School, rising through the ranks to become the inaugural Henry Mankin Professor of Orthopedic Surgery and Professor, Department of Molecular Genetics and Biochemistry. While at the University of Pittsburgh, he attained a master's in history and philosophy of science. In 1994, he was awarded a Doctor of Science by the University of Wales. He was recruited to Harvard Medical School in 1999 and then to the Mayo Clinic in 2013. So welcome.
Right, thank you. Well, thanks very much for giving me this opportunity to describe some of our work. I normally work on gene therapy, but this project has nothing to do with that, which is a nice change for me and probably for you too. And I'm going to start by pointing out that bone is very responsive to electrical forces, and this has been known for centuries and was codified by Julius Wolff in the 19th century. And you may have heard Fabi define regenerative rehabilitation as the restoration of function through the application of physical forces. And bone could indeed be a very good example of how this can work. And in the panel discussion last night, there was some question raised about what might be the low-hanging fruit for our discipline. And I think this could be one area where it can really work. And I think the orthopedists have been doing it for decades, and they just didn't realize it. Klosterhoff, who spoke yesterday, both showed a slide of a fracture that was healed with and without micromotion, and he got much better healing with micromotion. This was shown by Alan Goodship and forgetting the name of the chair of orthopedics at Harvard, at Oxford, but showed in a 1985 paper that in real human patients you could do this. So it's very much ripe for, I think, exploitation. Now, when you think of bone healing, you wonder why you need to have any fancy way to improve it, because we learn fractures heal themselves, so there wouldn't appear to be the need for anything regenerative to be superimposed. But the problem is that there are problems in healing ranging from fractures that won't heal to these very large defects that we heard a little bit about yesterday, which are just intrinsically too large to heal, even in a young, healthy person. So this next slide isn't showing, but I don't know why. But it was just an amplification of the previous slide that showed an X-ray of a bone that's a problematic fracture, and the fact that you can heal some of these with autograft bone, which is in limited quantities and comes with morbidity, allograft, which is dead, because to make the allograft germ-free, you basically kill the cells. And there's really no good way to treat these large mental defects. The method that's popular is to use recombinant bone morphogenetic protein 2, which is available commercially as the product Infuse. The recombinant protein is put on a collagen sponge, which is actually a lousy delivery system because it all disappears in a few hours. It has limited FDA's approved it for certain limited applications, but everybody uses it very widely in an off-label fashion, which has got a lot of people into trouble. It has some incremental improvement. The strange thing about recombinant human BMP2 is it works great in mice and rats. It works in rabbits and dogs. It works so-so in sheep, and by the time you get to the human where it came from, it only works a little bit. And nobody knows why. We thought it was a delivery problem to do with the sponge, which is why we apply gene therapy in other projects, but we don't yet know whether that's truly the reason. It's delivered to the patient because it's relatively inefficient in huge doses, milligram quantities, when naturally there would be nanogram quantities in a lesion. It's very expensive, and because used so much, there's a plethora of side effects, some of which are quite severe and weren't reported for till after several years of use, and there's been some scandals about that to do with the way it's used. Now, if you look at the way a long bone will naturally heal after a fracture, you first get a hematoma forming. The blood clot turns to cartilage, and the cartilage turns to immature or woven bone that eventually becomes mature lamellar bone. And the process that goes via cartilage is known as endochondral ossification. And the question is, can we improve this process by mechanical manipulation of the fracture site? This has been around for some time, as I alluded to in my opening comments, and the concept that's been attracted most attention is one called dynamization, and that's where you fix the fracture stiffly, rigidly at the beginning to allow the inflammation to die down and the healing to commence. And then once you're confident that's in good hands, you release and loosen the fixator so the forming bone can bear load. And in doing so, the idea is the bone then matures more quickly and the patient can weight bear more quickly than it otherwise would have been the case. And the person that popularized this was Di Bastiani from Verona, who actually started a company called Orthofix. It's still around, it's quite successful, that made the first external fixator where you could adjust the stiffness and turn it from very stiff to less stiff at the first indication of periosteal callus, which means the first radiologic sign that some healing is started. You now loosen it and allow mechanical forces to have their effect on the healing bone. My interest in this field was started when we had an engineer in the lab, Vida Glatt, and she came to me one day and said she was fed up with being the lab engineer and she wanted to do a PhD, and could she work with me? And for various complicated reasons, she enrolled at the University of Warwick back in the United Kingdom and did her PhD on the role of the mechanical forces on the healing of a large segmental defect in the rat femur, which is the model we've used for some considerable time in our lab. She stayed with me as a postdoc, went to Berlin, where there's a Julius Wolff Institute that studies this stuff, and has now come back to the United States. Just started an assistant professor's position at the University of Texas. So the rat data I'm about to show were done in conjunction with Vida. So going back to the schema I just showed you, where we're focusing on the conversion of cartilage as the earliest repaired tissue and its transformation to bone, we discussed what we would do as a project, and one of the things we've noticed, and this happens to be from a gene therapy project, but it could have been from anything really, that if a fixation is too loose on the defect, we get a large amount of cartilage formed, but it doesn't go on to form bone. And we knew from this and other evidence that under conditions of loose fixation, we get abundant cartilage. So we were wondering whether we shouldn't switch dynamization around, and instead of doing forward dynamization, which I talked about up to now, we actually reverse it, and whether the loose fixation at the beginning would promote the formation of cartilage, and then once we have this and we want it to convert to bone through the endochondral process, we should move over to stiff fixation. So we've applied this in our right segmental defect model. So it's a surgical procedure where we expose the femur, put on this external fixator, and then take out 5 millimeters of rat femur. This causes what's for the rat a large segmental defect, and it won't heal spontaneously. It's a critical size segmental defect. This is what it looks like intraoperatively. There's your 5 millimeters of missing bone. There's an external fixator, which is big and clunky, that we used in our early experiments. We don't use it anymore. And we've, in the lab, put all sorts of different things in it to see what effect on healing, whether it's genes, proteins, cells, tissue. In this case, we were using BMP2 to initiate the healing process and then applying an external fixator. Now, we needed to design a fixator which we could modulate in a quantitative fashion the stiffness, the axial stiffness, during the healing process. To do that, we worked in collaboration with Romana Mattis, who's at the AO Research Institute in Davos in Switzerland, who brings the expertise of Swiss watchmaking to making tiny fixators for mice and rats. And he was able to come up with something we could use in our experiments. It's shown here, where the thickness of this crossbar is varied, and depending on it, you get different stiffnesses. And the stiffnesses we used in our initial experiments are shown here. So what we're calling low stiffness is 114 newtons per millimeter, the medium one 185, and what we call the stiff one is 254. And I regret we use the terms low, medium, and high because it's all relative. And Bob Goldberg, who gave his talk yesterday, I believe I'm right in saying, and the next speaker probably knows more about this, theirs is down around 8 newtons per millimeter, so that would be extremely low by the standards of what we're using here. We also designed, or Romano also designed, a saw guide to make sure that this was reproducible and accurate every time. It would slip on the bone, and this takes what's known as a giggly saw, which is a serrated wire that you can pull through and do this, and then it takes out the piece of bone that you need to take out. And this is how it works in practice, where you apply it, you drill it, you put in the pins, you put on the sword guide, you pull on your giggly saw, and a 5 millimeter piece of femur comes out. And this is what it looks like in the operating room when we're working on the rat. And the point here is, during this 8-week period, which is the typical length we'd let an experiment run, in the absence of BMP2 or another osteogenic stimulus, we don't get healing, and the fixator takes the full weight across the femur. So the technology we're developing, it doesn't sort of resurrect the dead. It doesn't make a non-healing bone mysteriously heal. What we're trying to do is make what we know has some activity to be more efficient. So in the interest of time, I'm just going to show some of the key data. But if we look at the histology of what we find, it's shown up here with hematoxin, eosin up here, and safranin O and fast green down the bottom. But if we use the low stiff, these have got shifted over by a MAT to PC transition. But if we use the low stiffness fixator, and under all these conditions, we get a lot of bone. But this is disorganized, low-quality bone. We don't have good restoration of the cortices. And it's much, there's a large callus, much bigger than we'd see in normal bone. The medium stiffness one, again, we get lots of bone with this cyst in the middle that hasn't filled up. And we use the high stiffness fixator, we get residual cartilage, showing that the endochondral process has been delayed. When we use reverse dynamization, you can immediately see by the histology we're getting much better bone. These holes is where the pins were for the fixator, but we're getting good restoration of the cortices. The marrow is reforming within the healed bone, and we don't see any residual cartilage. And the cross-sectional area are closer to that of the normal rat femur. And if we look at this by microcomputed tomography, the 3D images, you can see that the profile of the bone is much more authentic here. Doesn't have discontinuities like there are with the high stiffness fixator. And again, in coronal and sagittal plane, you can see how we're getting good cortication. There's not an excess of bone in the marrow where there shouldn't be bone. There should be marrow. and the area is smaller. And again, you can see that better in cross-section where the cortices are smoother, well-formed, and there's none of this intramedullary bone, residual bone being formed. So we're now trying to see, having proved the principle, what the limits of this approach are in the rat model. And we've taken to even lower stiffness fixator to see if we could improve the healing even further. And to do this, we've got a fixator that has what we're calling very low stiffness, 25 newtons per millimeter. And we let this go for 2 weeks, let the rats heal for 2 weeks under conditions of very low stiffness, 25 newton millimeter or low, 114. You see here actually the collagen sponge containing the BMP2 looks like it's fallen out the defect under such low fixation and is forming the bone ectopically here. If you now impose the high stiffness after 2 weeks, which is what we typically do in this system, the low stiffness fixator works well, just like I showed you in the previous set of experiments, where it goes from this to this within a week, and then within 4 weeks it's looking better and better and better. The low stiffness fixator eventually catches up. These rats are very responsive to BMP2. The point here is when we have the reverse dynamization, this happens quicker and we get higher quality bone. Now, if we start off with a very low stiffness, this doesn't work. So under conditions of very low stiffness, the bone forms reluctantly, eventually catches up, but it's morphologically disturbed. And if you put reverse dynamization on top of it, it's no better. And in fact, we get this discontinuity, which will never go on to heal. So there's clearly a lower limit of axial stiffness to the fixator that we can use to get this to work properly. And if you look at the histology, again, in the low stiffness that's not dynamized, we have residual cartilage and lots of bone where it shouldn't be. If you, at 2 weeks, stiffen, you now get the smooth contours you're looking for, just a touch of cartilage in this particular rat, and good cortication. And if you have very low stiffness, it just doesn't work. And the reverse dynamization, if anything, makes it worse. And this would be an atrophic non-union, where we just have this big wodge of cartilage that isn't doing anything, and can actually begin to look like a joint, a pseudarthrosis, which you sometimes see. So from the rat data, we conclude that we get accelerated healing when we first fix at low stiffness, and after 2 weeks, change to high stiffness. There's advanced remodeling, forming of the cortices, the callus size is down, and so on and so forth, and recovery of mechanical strength. And now what we want to do is see if this works in sheep. So to this, I turn to another colleague, Slobodan Tepic, who's a mechanical engineer, got his PhD at MIT, worked at the AO Research Institute in Davos for a number of years, which is how I got to know him. And he then started his own company making orthopedic implants for dogs. So he has a company in Zurich called Kion, and I got him to design some sheep fixators. And the outline shown here, what it looks like in real life, is shown there. So this is a cadaveric sheep tibia. This is just a fracture line, but we're using a 3-centimeter defect in the sheep, which is a very challenging model for all sorts of reasons, not only biologically, because that's a huge defect in a large animal, but sheep are notorious for breaking the hardware when you try to stabilize fractures. So it's one of the models you have to use to go from a small animal to a human, and it's a real filter that separates the men from the boys when it comes to bone healing. So this is the fixator applied to a cadaveric sheep. The idea is that these 4 pins here, and these are pins that are used clinically in orthopedic surgery, so there should be no problems with the FDA in their application. The crossbar is the novel bit. These pins that go in at an angle are not rigidly attached to the crossbar, so that this provides loose fixation because we only have these 4 parallel pins supporting the defect. We can tighten them up with insertion of shims, so when we want to have stiff fixation, we can insert the shims, and then the axial stiffness of this device goes up by about 2.5-fold. And we know that because we've tested it in a material testing device. This is work done at Mayo, and that's what it looks like. So when we started doing sheep surgery this year, and we're going to do our 3rd sheep next week, and this is intraoperative pictures, and here's the device on the sheep. And this is the post-operative X-ray you get. We're going to let these sheep go out for 6 months, and there's 4 groups that have stiff, loose, forward dynamization like is presently used clinically, and then reverse dynamization, which is the one we really want to see how it works. Into this gap goes BMP2 or Infuse, which was donated by Medtronic. So what we're now doing, in addition to the sheep studies, is we want to find out how low we can go with the concentration of BMP2. I mentioned that it's very expensive, used in high doses, and the high doses give side effects. So if we think we can reduce the requirement for BMP2 to heal complicated fractures, we will both lower the cost and reduce the side effects, and allow earlier weight bearing if mechanical strength can be restored at an earlier time. And that's very important for patients when they can weight bear. And then if this holds together and we're convinced this is going to be something that takes us forward, we need to know what the mechanisms are. And I said at the beginning that this project was predicated on the fact that we thought we would generate a large amount of cartilage quickly while the fixation was loose, and then it would turn to bone rapidly when we stiffened it. We got the increase in healing and the acceleration and the improved bone quality, but we've not seen any cartilage. So we got the right result for the wrong reason, and we need to go back and find out whether what's happening has to do with the responses of the mesenchymal cells that are differentiating into osteoblasts under the influence of the mechanical force, or whether it's some other. There's a number of different possible explanations which we need to look at. So with that, I'm just going to acknowledge the people who've worked on the project, and I mentioned the key ones as we've gone through. Medtronic supplied the BMP2 and the Infuse. It's been funded by the AO Research Foundation and by the Department of Defense, and thank you for your attention.